one of the following pathologies is most likely to give the appearances below? So what you see here is a flame-shaped hemorrhage here. So this is a flame-shaped hemorrhage. You can see prominent temporal horn of the lateral ventricle, and you could not see any sulcal gyral differentiation is not clearly seen here because there is significant diffuse cerebral edema. And there is a mass effect here because of the bleed. The anterior interhemispheric part is being compressed and displaced. The anterior part of the falls is being shifted. You can see SAH at various places. So this is diffuse cerebral edema, cisternal bleed, hydrocephalus, and a flame-shaped hemorrhage. So what is the probable aneurysm? It could be. It is Acomm aneurysm. So it is the anterior communicating. So this is the classical picture, the flame-shaped hemorrhage seen in anterior communicating artery aneurysms. So this is one aneurysm which we should be very much familiar with. The anatomy, which can most of the time anterior communicating artery aneurysms are associated with abnormal anatomies. So understanding the anatomy of the anterior communicating artery aneurysms through the angiogram is very, very important to avoid surprises intraoperatively. And this is the commonest aneurysm which we see in our clinical practice. So this is a single most common site of aneurysm presenting with SAH. It may additionally present with diabetes insipidus or hypothalamic dysfunction. So in the CT scan, we see blood in the anterior interhemispheric fissure, intraventricular hematoma, acute hydrocephalus, and patient can present with apathy and ebulia as a result of this. So the angiographic consideration, it is very, very important. You evaluate the contralateral carotid to determine if both anterior cerebral artery fill the aneurysm. And if the aneurysm fills with one side only, it is desirable to inject the other side while cross-compressing the side that fills the aneurysm to see if collateral flow is present or not. So especially in anterior communicating artery aneurysm, the collateral circulation needs to be checked during the angiogram. And also determine if either carotid fills both the anterior cerebral artery or if each anterior cerebral artery fills from the ipsilateral carotid injection. So that is, there are various anatomical variants of anterior communicating artery. So in order to determine any abnormal anatomical variant, this needs to be addressed. So the approaches for the anterior communicating artery is through the pterional approach, subfrontal approach, anterior interhemispherical approach, and transcallosal approach. The subfrontal approach is useful, especially for aneurysms pointing superiorly when there is a large amount of frontal blood clot. The anterior interhemispheric approach is contraindicated for anteriorly pointing aneurysms. So it is mainly done for the pericallosal artery aneurysm, which I have shown previously. For the proximal and the distal pericallosal artery aneurysm, you can go with the interhemispherical approach. So first, what are the various approaches? Steps involved in the approaching the anterior communicating artery aneurysms. So step one is as I said, the delineate along dissection along the medial border of ICA, inferior border of the A1 ACA, because here you don't have any tributaries. That is the optico-carotid triangle. So follow the A1 ACA. So that should be the first and foremost thing. And then go along the A2 segment, ipsilateral A2 segment, and then go across the midline via the anterior communicating artery. Define the contralateral A1. Define the contralateral A1, and then enter through the distal interhemispheric fissure. Define the contralateral A2. Define the contralateral A2. And then the separating the perforators from the aneurysmal neck has to be done. So once all these steps are done, the aneurysm neck is free and is available for clipping. So remember, dissection along the ipsilateral A1, define the ipsilateral A2, cross the midline, and define the contralateral A1, and then along the distal interhemispheric fissure, dissect along the contralateral A2, separate the neck of the aneurysm from the perforators, and now the neck is ready to be clipped. So the various projection of the aneurysm. So you can have a superior projection, you can have inferior, anterior, and posterior. So the superior projection, the anterior projection, the inferior projection, and the posterior projections. So based on the projection, the steps of approach also varies accordingly. So most of the thing will be common and there will be certain unique steps that alone needs to be remembered. So this is an inferiorly projecting aneurysm. So here the steps are the same initially. Ipsilateral A1, ipsilateral A2, and cross the midline via the anterior communicating artery. And fourth one, instead of tracing the contralateral A1, you need to dissect along the contralateral A2. Okay, that is important. Contralateral A2. So dissect along the contralateral A2 and then develop a plane under the neck of the aneurysm and then inspect the contralateral A1. So once all these steps are done, now the neck is ready to be clipped. So this is an inferiorly projecting aneurysm and this is an anteriorly projecting aneurysm. So this is an anteriorly projecting aneurysm. So again, dissect along the ipsilateral A1, along the ipsilateral A2 and cross the midline via the anterior communicating artery. Define the contralateral A1 and enter the distal interhemispheric fissure and define the contralateral A2 and separate the perforators, and now the neck is ready to be clipped. And for the superiorly projecting aneurysm, again it is dissect along the ipsilateral A1, along the ipsilateral A2, cross the midline along Acomm, define the contralateral A1 and then trace the contralateral A2 and define the ipsilateral along the interhemispheric fissure, define the ipsilateral A2 segment and then separate along the perforators and then the neck is now ready. So here remember that delineation or dissection along the ipsilateral A2 comes at the last. So the dissection along the ipsilateral A2 comes at the last in a superiorly projecting aneurysm. So whether it is a superior projection or an anterior projection, so this needs to be made with the angiogram. So